Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Today, we're kicking things off with someone incredibly special to me, my mom. A CRNA with 25 years of experience, she's not only watched me survive the trials and tribulations of nurse anesthesia school, but she's also paved the way with an integrative and adaptive approach to learning the latest in anesthesia practice. In 2020, she went back to school to earn her DNP, and guess what? I couldn't let her be the only DNP prepared CRNA in the family, so again, I followed in her footsteps. Today, we're talking about the highs, lows, and everything in between, from school to practice, and let me tell you, I am her number one fan. So let's get started. Okay, my pink-haired sister just stepped out. She is our unofficial podcast producer here, because she podcasts all the time. But we're going to start with an unboxing. We're going to unbox my new sweatshirts.
How can I help you?
New merch. Oh, you're good. New merch here on our first episode of Farm Life with my mom, Mary Wilson. Oh my goodness, they are so cute. And Dad.
Printed by Aussie Silkscreen.
My dad printed these. Ivy League CRNA. Do you want one?
Of course I want one.
Who doesn't? Anyways, I will be
Nice.
selling them. So
Nice.
love them. Love Dad.
Good color.
Okay, on to serious business here. I hope that mic captured everything. I'm here with my mom, who has been a CRNA for 25 years. From a standpoint of your daughter, me, going into anesthesia, I grew up literally going with you to private practice gigs and sitting with you in the operating room. And I remember when my brother went with my mom to shadow her at a private practice setting, he told my mom, like, I love how you just do something at the beginning and the end, and that's it. And we all laughed because we knew that wasn't actually factual. That what was your reply to him saying that?
Sometimes people make it look easy.
Yeah, and you're doing your job if it looks easy, right?
Exactly.
So the patient is stable and everything's going well.
Right.
You unlock that for me. But the point of this podcast is to highlight pharmacology and talk to experts in the field. And I wanted to start it off like fun and light, interviewing my mom and our experiences in CRNA school, because we had pretty different experiences. But we'll start off kind of about your journey. Like, what brought you to anesthesia? Like, tell us from the beginning, like, where did you start? I know Granny, my grandmother, worked in the hospital cafeteria. She was one of the kitchen cooks in the cafeteria, correct?
She started that way, and then she was the assistant director for the food processing and cafeteria there.
Dang, Granny moving on up.
Yeah.
And that was your first exposure to the hospital setting?
Yes.
And so what?
She was a CNA before that. She was a CNA at hospitals. at like retirement homes, and so that was kind of my first initiation into her being part of a hospital. And then it was I grew up at St. Bernardine's in San Bernardino.
So what did you?
I didn't want to be. I didn't want to be in the health profession. That is not something that I wanted to do.
Right.
I initially...
Same girl, same.
Is that what you're asking me?
Yeah, I just want to talk about your journey into how did you become a CRNA?
So I was a theater major for a couple years and then decided that wasn't the life that I wanted to have for myself. But along the journey, people had told me my whole life that I should become a nurse. And I was like, I do not want to be a nurse. I don't want to take care of people. That wasn't something that I wanted to do. But then I saw that my mom worked in the hospital and I was used to that. And then I was like, well, I could probably do it in 2 years and get my AA degree. And then by that time, I had gotten married and was pregnant. And so I wanted to do something quickly. So I finished school. I graduated Crystal was born in February, your sister, your oldest, the one with the pink hair. And then I graduated in June from an AA degree. And I worked for about 12 years and decided I wanted to go back, get my BSN. So got my BSN from University of Phoenix. I didn't realize that there was an anesthesia program. And so when I was in my nursing program, I worked in the OR as kind of an orderly, putting together processing instruments. Mm-hmm. So that got me my first introduction into the OR. And that just kind of seemed like that would probably be my jam once I got out of nursing school. But actually, I worked in ICU, CCU, which was kind of catapulted me into being able to apply for an anesthetist position when a school opened up and I figured out which school to go to. And so then I found Kaiser School of Anesthesia, applied in December, and thanks to Michael Boydum, shout out to Michael. I
have a lot of shout outs throughout this. So.
Michael Boydum is a great mentor of mine and yours.
Yes. Yeah.
And anyway, so I then started the program. It got accepted in February and started in August. So I've been a nurse for about 12 years before I went to anesthesia school.
And doing a bunch of different things, which is amazing. And then one of the CRNAs that worked at St. Bernardine's that introduced my mom to the world of anesthesia was actually my preceptor, one of my first preceptors at the facility locally. So it's nice. It's just such a small world. Anesthesia,
it's a very small world.
You always know people that know people, and that's kind of the beauty of being a nurse anesthetist, is that someone always knows somebody.
Yeah.
Good or bad.
Well,
always
be
treat your student
kind.
with respect. Here's the thing. You don't have to remember. What did you say? Did you tell me this? No, I think I told you this. You don't have to remember whether or not you were nice or mean to a student if you're always just kind. And
oh yeah, that was not me. It must have been you saying it's me.
Yeah, so it's true, right?
Yeah, but it's in life in the anesthesia. I mean, nurse anesthetists, it's a very small community. No matter where you go, no matter what organization. Sometimes a lot of times it will tie back to itself. So after you're out, it's good to have connections. Relationships are what it's all about. So that later on, you never know when you're going to need a job doing something specific, and you got to call on those people.
Yeah,
I did that just yesterday.
Yeah, the community again is just so small, and people have. That's why I said if you want to move to Montana tomorrow, you probably have a student that you had or a preceptor that you have that works in Montana in some type of capacity. So
or someone from Canada or
any of the agencies or
that you're affiliated with. Yeah. Helps out.
So since you've been a CRNA, so 25 years, how would you say pharmacology has kind of changed? I mean, it's changed even in the 9 years that I've been a CRNA. So what's one of the most significant ways you've seen it change?
I think the opiates,
that's our shtick.
That's
non-opiate anesthesia is our shtick.
But before that, it was the introduction of propofol, because before that we had, what was there? Oh no, it was.
You're old, lady.
I know. I had
barbiturates or what?
No, it was sodium pentothal. We induced with sodium pentothal.
Yeah.
There was no propofol, and so then when
halothane, just ether in.
No, I didn't do halothane. I didn't do ether. I'm not that old. But pancuronium was a muscle relaxant for long anesthetics for long surgeries, that kind of thing. So the introduction to shorter acting non-depolarizing agents, as well as induction agents, and then the use of non-opiate and regional blocks. That's the most significant, I think, recently.
Yeah, we love us some regional blocks and non-opioid anesthetics. So do you remember the first time giving propofol?
I don't remember the first time giving propofol, but I do remember the first time we started introducing propofol to GI labs. That was, John Delabroca was another CRNA that we know. Shout out to John. We started the GI clinics over at Kaiser, and people couldn't believe that we didn't have to use Demerol and Versed at the time, and we could just whip them through with just propofol. Yeah, so that was a big plus. Yeah, it was a big plus. Recovery was no time.
So then let's talk about kind of the evolution of pharmacology. And have you seen any drugs kind of fall off the market? We kind of talked about.
But there are other ones. So what was that one?
Are you talking about alfentanil? Because I threw a small funeral for alfentanil.
No, not alfentanil. I never used that.
Bring it back.
There was a short acting. It acted like Sux. It was It started with an M. It was not like Zemuron. It was kind of like Zemuron, but it was a different.
I think we still teach it in the textbooks. Mercurion or something.
Yeah, Mercurion.
Something like
that. Anyways,
once we have my pink-haired producer sister on payroll, we'll have her Googling this stuff on the site.
Yeah. Anyway, so that's...
Drop it in the comments if you remember the name of that drug.
Yeah. So it was very short acting. It acted like Sucks. You didn't really have to reverse it, but it was a non-depolarizing. So that dropped off the market.
Because they came up with shorter acting medications.
No, not really.
Oh.
No,
Were there side effects or?
I have no idea why they dropped it. I would have to go back in the research and find out. But it was years ago.
Alfentanil and sufentanil dropped off the market for manufacturing reasons, I think. I mean, we use sufentanil a lot for our total Tiva anesthetics. Now we're using remifentanil, which there's the hyperalgesia that is associated with it that you kind of have to get ahead, or tachyphylaxis that's associated with remifentanil. But those two drugs, those are the ones that I've held small funerals for, because I felt like they were great drugs when you needed to use them. Yeah,
and for me, I was never a huge narcotic proponent in the OR, so I didn't use alfentanil a lot.
You did a narcotic wake up here and there.
Oh no. Well, but just for fentanyl, sufentanil once in a while, but not a lot. Dilaudid. Once in a while, but not a lot. I still wasn't a huge Dilaudid fan either.
Because it depends on what kind of cases you're doing.
Exactly.
Also.
Because at our facility, even back in the day, we didn't do, some of them were hospitalized, obviously, but we had a lot of outpatient. The turnarounds need to be fast. And so anything that delayed wake up, we really didn't want to give. So, but there are still a lot of CRNAs that are huge narcotic proponents, which is fine. Lots of different ways to give anesthesia.
And they always say there's a million ways to skin a cat, which we need to think of a new way to communicate that, because that's kind of an aggressive way to say that.
It's an art. There's lots of artists, lots of ways to paint a picture.
Yeah. Somebody tell the story or tell the analogy. Okay, I'll tell you the analogy. Forget it. You can tell your analogy later. Right. My analogy, someone told me, one of my preceptors, at one of the facilities I was at, I won't name drop, but they told me that an anesthetic is kind of like building a house or building a wall. And, you can the drywall, I know nothing about construction, okay, so there's that. But building a wall, you can put the drywall on it at the end to make it all look pretty, but it's the foundations and the things underneath the wall that make the wall sturdy and make the wall a whole wall and not fall over, right? So that's kind of an anesthetic. The SIVO and the gas is kind of the drywall you put in at the end, but it's all the other medications that we add up and are synergistic throughout the anesthetic that makes it a strong anesthetic. So
yeah, and I think you can go beyond that, actually, is that...
Oh, not Mary perfecting my analogy.
No. So what I tend to tell my students is that all that's important, but you also need to look at this patient postoperatively, long term. Yeah. You want to give the type of anesthetic that is going to be most beneficial to them in 12 hours, 18 hours, 24 hours post surgery.
Yeah.
Right? You want to make sure they're comfortable in the ways that we get them comfortable, like regional blocks or whatever. Your anesthetic is not just for this 3 hours or 2 hours or 1 hour that you're delivering the anesthesia, right? Yeah. Same thing. It's for afterwards. It's in recovery. It's for at home. It's for in the hospital. Whatever. It's same thing.
Yeah, that's great. So in terms of different patient populations that you've worked with in your practice, pediatric dental anesthesia. So for those, I kind of did an intro to this episode, but my mom graduated in 2020 with her DNP, and a part of her DNP project was developing guidelines for outpatient dental pediatric anesthesia. And as a part of that, what medications, you don't have to go into dosages necessarily, although I guess you can. I'm trying to decide whether or not we're gonna include dosages in this. But medications that you use in that patient population specifically for a specific reason, and kind of why you would use that in that setting.
So again, I'm a type of anesthetist that it does it holistically. So I want to give the patient what they need at that moment in time. I don't do a lot of pre-medication. I don't pre-medicate with atropine or with Robenal or anything like that to dry up secretions or to prevent bradycardia in kids. I don't do any of that. So my drug of choice for children when I'm giving anesthesia in the dental office for non-intubated, just sedated, but basically like a general anesthetic, is propofol. And then an adjunct to that would be Precedex. So I give 0.5 mics per kilogram if they need it. And kids that have irritable airways, you can get by with a lot with a little bit of Precedex. Like if you give propofol and the kid's coughing and just won't kind of settle down for you, as having respiratory issues, if you give a little bit of Precedex, it tends to smooth out that anesthetic. You can give less propofol, and then, the wake up is better for them. And then you don't have the spasms that you normally would see.
Yeah, we are huge proponents for Precedex. I have self-proclaimed title of Precedex queen myself, because in our department, some of my colleagues call it the essential oil of anesthesia, which we have that argument, because I always say it's user error at that point, because Precedex is such an amazing drug. And anecdotally, I delivered my 4th child at my mom's facility that she works at, and they did a non-opioid anesthetic for me as a mom going through a C-section. So the spinal had Precedex in it, no Duramorph, although they really wanted me to do Duramorph because I think they just wanted my pain to be covered for sure, and I told them no. So they did Precedex in my spinal intrathecal, and then a bilateral tap block with Exparel, which is like not standard of care, but I did request that and they were able to oblige. And then I got IV Precedex for the shivering that associated with my side attack that I took intraoperatively. And anecdotally, as a patient, I'm like, I was really worried about nausea, vomiting, and constipation. I mean, as a pregnant woman, you're already dealing with some of these things, and you don't want to go into the postpartum period with it being even worse. And so I felt like the facility did a great job, like advocating for me. And, even though I was probably the most annoying patient of the day, or most stressful patient of the day, I mean, I didn't have to I did Tylenol and Motrin postoperatively, and it made such a difference. I had nothing to compare it to because my other deliveries weren't via C-section, but, I've seen the benefits personally of Precedex. So I would say I'm even more of a proponent for using Precedex for analgesia in the operating room.
Yeah, and like we were talking about earlier, it's the aftercare. Yeah. It's the nausea and vomiting. It's the constipation. All the things that interact with your surgery that you just don't want to happen on top of having the surgery itself and taking care of your baby, or taking care of yourself afterwards. Yeah, it's just a great drug.
It is.
It's a great drug.
So if you don't like it, just get out of here.
Make your comments and we'll respond. We'll rebuttal. Trust me.
So let's talk about a case where pharmacology played a key role. Like is there any case specifically where it changed patient care for you? Even like the request cases you get. So if you get a request case from someone that that says, hey, Mary, can you do my anesthetic this day for, let's just say, a hysterectomy, like randomly, what type of anesthetic would you provide for that patient to kind of give them the experience? Especially because if you know that person, because what's a bummer is like we don't really follow these patients, right? We have our lineup of patients, we're done, we don't see them postoperatively. Sometimes if I have, I will go back and look at the chart, what the PACU nurses gave, or if they're admitted, what the nurses have been struggling with, or but it's hard. We don't have a lot of time to do that. But with friends, and when people come in with request cases,
you get feedback.
We get feedback, and that's kind of nice to get. So if, let's say I came to you for a hysterectomy, what type of anesthetic would you give? Or what would you recommend?
So I try to stick with my regime of doing the same for every...
regimen, Mary.
Oh, sorry. Regimen.
Regime. Very different.
It's a regime. No, it's a regimen. Okay. So for...
that's just how I say it.
For what I do for every patient, I try not to alter it too much because, it's a friend or it's whatever, and you just don't want to change something and have something happen because it was a friend and you did it differently. So it would depend on how nervous they are to start with. I don't give Versed, and I know a lot of people,
it's a hot debate in anesthesia these days.
A hot debate. They want to debate that with me, but I will give Versed if people ask me for it or if they seem extremely nervous. But for me, it just delays wake up. And again, I want to go to the operating room. I want the person that I love, my friend, whatever, knowing everybody that's in the room. If they haven't handpicked them, I would like them to know who's there. They can speak up, right? Yeah. And they can't remember, so they get to speak up and be part of the timeout. The thing that we do once we go into the operating room to make sure that we have all the things we need. And then I know this sounds silly, but I will do lavender. Like now we have little lavender patches on, but way before that,
a real essential oil, people. Not Precedex as an essential oil.
No,
real essential oil.
But way before that, I would wrap their head and it would be kind of like soaked in lavender, and then ask the patient or my friend,
okay, that's wild,
what kind of music they like to listen to.
Yeah.
Put that jam on, and then slowly start inducing a little bit of
like Kendrick Lamar.
Precedex, a little bit of ketamine, start pre-oxygenating, get that oxygen deep down into their lungs. And normally I don't give any opiates. I rely on Precedex and ketamine, give my propofol and Zemuron, and mask them a little bit. And then once they're asleep, I'll give some mag, like 1 to 2 grams, depending upon the patient's weight. Give Toradol, of course, if it's not contraindicated at the end, Decadron, Zofran, and do a block, whatever type of procedure. A lot of times the surgeon will do an internal tap block, but if not, then before we wake the patient up and before we reverse them, then we'll have the anesthesiologist or the anesthetist do a tap block.
Yeah, that's awesome.
Yeah. So that's normally, I'm not, if it looks like the patient needs something more, I will give fentanyl to top it off, but normally they don't need it.
Which is nice. I feel like I did read a study, this was years
if it's a good
ago,
block.
I don't even know how many years ago, I read a study in the AANA journal that was about giving Esmolol instead of a narcotic for tachycardia intraoperatively, because a lot of the times we see tachycardia and we treat tachycardia with narcotics, and then in the case the patient does well, but did they actually need that narcotic, right? So I think that, especially with Precedex and the bradycardia that comes with Precedex, which I always tell people that you will see a profound hypotension if the patient is hypovolemic. There is that component that I've seen clinically with Precedex, but in general, when I worked at a local pediatric like level 1 trauma center, they would call it a benign bradycardia, where it really wouldn't affect cardiac output and blood pressure, but it would affect the heart rate, not to a point where it would affect any other hemodynamics.
Yeah. The other thing I will say that on top of that, I run a propofol drip.
Oh, nice, for antiemetic.
Yes, for antiemetic, and then as well as, so then I can decrease a little bit of the volatile agent because it will create a little bit of hypotension too, but it makes them nice and comfy, like 20 mics per kilogram.
So what is we're going to kind of dive into like SRNA advice and wisdom. What would you say is one medication that you think every SRNA should know? I mean, we should know all of them, right? All of them. But I guess your favorite one to teach. Let's do that. Your favorite one to teach that you think that is very important for SRNAs to know.
Well, there's, I think protamine. Protamine's a huge one.
Oh, yeah.
Just because of the reaction, from them being on NPH. And then I've seen it happen where the protamine was given a little bit too quickly, and then the patient actually didn't have a great.
Because if you push protamine too quickly, they can go into hypotension and potentially cardiovascular collapse.
And if you think about the patients that are actually getting protamine, they're usually vascular patients or renal patients, right? That you have to heparinize them during the procedure. So you give it slowly. It's just taught me things, through QM or whatever, and it doesn't necessarily have to be mine, but even somebody else's. It teaches me how to better give an anesthetic. So now I dilute it. I never used to dilute it before. I would just push it really slowly. Now I dilute it, hang a bag, and do it, and let it drip slowly.
I did the same thing.
Bam!
Yeah, I put it in 100 cc bag.
Yeah, me too.
ml bag of saline.
Yeah.
And you'll never regret it going slower. And if the patient can tolerate that 100 mLs, which most likely they can tolerate 100 mLs, but it just, you don't have to worry about it. You can worry about all the rest of the picture if that's just slowly going, and then telling the surgeon once it's in is just easier. And
and I think another one
is safer.
I think another one is locals. Know your max dose of locals, because the surgeon's gonna ask you, and then if you can.
Which has been a controversial thing. So I posted a TikTok and reel about the local anesthetic dose, and the debate in the chat was like, the surgeon should know what the dose is. And here's the thing, guys, we are all a team in the operating room. One CRNA that I worked with said, like, anesthesia providers, we are the guardian angel of the OR. So we have this like literal seat at the head of the bed where we're looking at everything. We're making sure that the surgeon didn't accidentally hit their elbow on the side of something and now they're not sterile, right? We're looking at like whether or not the dressing becomes saturated when they put it on because they can't see the blood that's underneath the patient and now the dressing's kind of saturated. Like all these little details are so important. So if a surgeon asks me what the max dose is, I'm not gonna argue with them. It's what's safest for the patient. And I'm sure that the surgeon could look it up or whatever, but they're also wondering if we've given a block, if we've given additional local anesthesia intravenously, right, with induction. So there are other components where we as anesthesia providers have given local that they want to make sure that they're within the realm of a safe dose.
Yeah, I mean, you want to, if they have local on the field and they're giving 20 cc's of something and you don't know what that max doses, that's a problem if they're going into toxicity. I mean, you could stand up and go, hey, that's going to,
be too much.
Too much for them. So you cannot give this patient that much. We are the best patient advocate in that room.
Yeah.
Because we're the ones that are looking at everything.
Angel.
Yeah. Well, our advocate. I would say I am your advocate. Because we see everything. We do. We see everything. If they're suctioning too much, what's the blood loss?
Yes, we're listening and looking all the time.
Gotta
I
be
always
vigilant.
tell patients we're watching every breath, every beat of your heart, all of those things. So let's talk about your advice. You had a great advice the last time we filmed this. This is round 2, but because look at this lighting, it's so much better. What's your number 1 piece of advice for SRNAs?
I think grace, giving yourself grace, knowing that you're human. Not everybody's perfect. You are a mother, a brother, a sister, a friend to somebody. So that is going to school and being in a clinical or being in didactic overwhelms you, and that is not the whole of who you are. You are another piece outside of that. So there are going to be days that you go in and you don't feel great, or someone's going to make you feel not great about yourself, and don't let that get to you. Find a way to deal with that, someplace to put it. Exercise, read a book, call a therapist, call a friend, call a mom, and have that discussion. But don't give up, One student actually told me one time, she said, I work hard at being a student. You could tell she was a very good student. She goes, I work hard at being a student because I took someone's place in this program. And I appreciate that. I know that. So I'm going to work hard at making sure that I deserve this. So, you just have to have grace for yourself,
Yeah, I agree. And I think that my main source of mental stability throughout my CRNA program was my mom, and I had that benefit. I'm a Nepo baby. I always say I'm a CRNA Nepo baby, which, does everyone know what a Nepo baby is? I feel like nobody laughs when I say that. And I'm like, no, do you get it? I'm a Nepo baby in anesthesia. But, I had days in clinical, we kind of spoke to this the last time, I had struggles along the way, and calling you on my lunch break and saying I cannot go back in there. This lady told me my shoes are dirty and that my classmates are better than me and I cannot do this. And you were like, you have to just hold your head up high, go back in there, just survive this day. It's one day, and then kind of on to the next day. Take it day by day.
Yeah, realize someone else loves you. You know what I mean? It's somebody else is going to be kind to you at the end of the day that does not relate to this at all. That just because they're having a bad day or they feel like lashing out, they have problems too. You have to kind of go through that and just figure out for yourself that's, and I couldn't tell you ahead of time that that's how it was going to be. Even though I knew that there were going to be some people that treated you that way, I couldn't prepare you for it. I could only let you kind of go through it, and then us have a conversation afterwards about it.
Yeah, because there's really no preparing someone for CRNA school. I've even had friends that have gone through CRNA school now, and before, they were like, oh, I've been a charge nurse in ICU for 5 years, and I was the opposite. I had a year and a half in ICU before I went back to anesthesia school, and so I was like, oh, okay, yeah, you know what it's like. And then they're they actually came to our facility, and I was clinical coordinator, and I'm like, how's it going? And they were like, oh my God, this is not what I thought it was going to be. And that's why I love the juxtaposition of our experiences, because you had been a nurse for 12 years and I had been a nurse for 12 months. But we both had different difficulties. I struggled with imposter syndrome. I struggled with, did I really earn this seat? My mom is who she is. And somebody told me, one of my mentors, just telling my personal story, one of my mentors recently told me, Chloe, you need to change your mindset, and you got here despite who your mom is, and she had these big shoes to fill, but you stepped up and were able to complete that, knowing your mom knows a lot of these people, and there was a lot of pressure on
It's
me.
harder on you.
Well,
it's been harder on you,
but it was very much I can't screw this up. Everyone knows my mom. What are they going to think of me? What are they going to think of her? Did I earn this? And, but with you, I feel like you had been a nurse for so long that going back, I hate saying the bottom of the totem pole because it really shouldn't be like that in healthcare, but, you kind of had to go back.
You're a beginning learner.
You're a beginning learner. And so I always tell people, it doesn't matter if you've been a nurse for a year and a half or you've been a nurse for 12 years, you're going to struggle. There will be struggles.
Yeah. And I think for me, because I hadn't been in school for quite some time when I went back, and my schooling was hodgepodge, it was my AA from a community college, then my BSN from University of Phoenix, which some people would probably look down upon. It wasn't a university, so to speak, but I got a lot out of it. And then I went back. And so I hadn't had that didactic sitting in the classroom. And I had my own struggles. You know, I was older. You know, I was 35 when I went back to school, and I had 3 children. So it was very different. I was a mother, I was a wife. And so going into it, I had to keep remembering that too. When people would, and they did the same thing, you know, treated me sometimes, you know, poorly. And I would just have to think to myself, well, I'm a mom, I'm more than what this is today.
Yeah, and I think that's the big takeaway is that, you know, I told you one of my mentors, and I posted on Instagram and stuff, that one of my mentors also told me, and a separate mentor said, like, you know, you work so hard to become a CRNA, you're busting your butt, but at the end of the day, you are a mom, you are a sister, you are a human, and although this seems like everything in this moment, and you do need to work hard, don't get me wrong, but it's not everything.
And most of the time you can find someone. There's somebody in your program that is your type of personality, or it's your person, right? And so I did have that too, where I had a couple, Donna Funky, another shout out, and Michael.
My mom's name dropping left and right. I'm so
John Nagelhout, Michael Boydum. They were my go-to. If I was struggling, you know, I would go to them and say, hey, I'm struggling, you know, what do I do? And then they would help me through that.
Yeah, and that's another takeaway too, is that like faculty truly want to see you succeed. And I know students walk on eggshells like, oh, I'm going to get kicked out left and right. Like at the end of the day, we don't want to see you fail, and faculty want to see you succeed. And we have avenues for support and resources, but the hard work has to be there, right?
Yeah.
Like
the motivation and the hard work.
Yes.
You just have to be motivated, really, to learn.
Yep, and the eagerness.
Be open to it.
Yeah, totally. Well, this was a great first episode. I'm so glad you're here.
Well, thank you. I feel privileged to be your first interview.
If you have any questions for Mama Mary here, drop them in the comments or DM me, whatever. We're happy to answer any additional questions via any different avenue we can. I love you.
I love you
so much.
Thank you.
You're the best.
Thank you.
And Mary insisted we wear our white coats. She showed up wearing hers, so that is why we're in these. I'm not going to be doing this on every episode, but for Mama Mary,
I never get to wear it.
We'll do it. Yeah, there we go. They're lab coats. They're not white coats. I don't know. I don't want to get political here. Thanks for being with us.
Thank you.
Love you.
Thank you. Love you.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.